Thank you. Okay. So I am a geriatric psychiatrist here at Toronto Rehab. I'm also a scientist at Toronto Rehab, and I study the relationship between depression, the treatment for depression, and falls in older adults. So I'm going to talk to you today particularly about depression and falls and why we think about that. So I'm going to review the association between depression and falls, how strong is that relationship in older adults, and also a little bit about the relationship between depression and bone health in older adults, so the risk of older adults who are depressed actually breaking bones. And finally, I'm going to talk about how we might change our practice based on this information. So how can we prevent falls in older adults who are depressed? So to start off, we know that falls are a common event in older adults. So falls happen, am I supposed to say on this side? Sorry. Falls happen in about a third of older adults every year, and about half of those people who fall are falling multiple times. 10% of those will have injuries. So falls are common in older adults. Depression is also common in older adults. So about 15% of older adults will have what we call clinically significant depressive symptoms. So those are depressive symptoms that are strong enough that will impact on their daily function. About 10%, nearly 10% of older adults now are on antidepressant medications. So we have two phenomena that are actually very common in older adults. And as you'd expect, there'd be some overlap between these two phenomena. But the overlap is actually much more than we would expect by chance. So if you look at older adults who are depressed, instead of a third of them falling every year, it's actually closer to 50% of older adults who are depressed that fall every year. And when you look at the relationship, the odds of falling if you're depressed is about 4 times greater than someone who is not depressed when you're older. So there is a clear evidence that it's a risk factor for falling. And there are a number of ways in which depression and falling are associated in older adults, a number of different sort of pathways or mechanisms that we might think about. So I'm going to go through each of these separate pathways in turn, but just an overview, we're talking about this actual symptoms of depression can, in someone who is vulnerable, predispose them to falling. Some of the treatments for depression can put someone at risk of falling. There are a number of common risk factors that link depression and falling. So medical conditions, for example, that predispose you to either of them. And of course, older adults who fall are especially those who fall a lot or who develop disability as a result of their falling are more likely to develop depression over time. So thinking about the symptoms of depression and the way in which that's related to falls, older adults who are depressed are inattentive. They have impairments in their concentration and their thinking. They're less likely to be aware of their or focused on their environment, and they're thus more likely to fall. They have impairments in what's called executive functioning, and we know impaired executive functioning means that they have more difficulty with things like multitasking or attending to complicated environments, and also more difficulty in planning and negotiating their environment. Fatigue and low physical activity are both risks for falling. People who are depressed sleep poorly, they have insomnia. They can develop malnutrition if they have very poor eating habits. Agitation and anxiety can drive someone. They might be moving a lot more. They might be preoccupied internally with anxious thoughts, and so again, not attending to their environment. Fear of falling is a very common symptom in older adults who are depressed, and while a certain amount of caution perhaps around falling may be appropriate, an actual fear of falling can be counterproductive, and older adults who are fearful of falling fall more often. Now, specifically, I want to talk a bit about gait and depression. So we know that older adults who are depressed walk differently, and that this change in gait may predispose them to falling. People who are older have changes in their psychomotor, who are depressed have changes in their psychomotor speed, so they walk more slowly. They also walk more cautiously, and that may be related to their fear of falling. And so what we know is that excessively cautious gait is actually maladaptive. People are guarding and walking in a way that does not actually promote their stability, which actually makes them more likely to fall. They may have more variability in the gait, some more difficulty regulating their gait in terms of a regular pattern of walking. And when you have executive dysfunction, your gait is more severely impaired in environments where there are lots of distractions. So if they are internally distracted, perhaps by their anxious thoughts, or in an environment that's complicated, like where there are a lot of people around or on a busy street, they're less likely to be able to put as much attention as they need to their walking, more likely to fall. So the treatments for depression also increase the risk for falling. And this includes not just antidepressant medications, but older adults who are depressed are more likely to be put on sleeping pills by their family doctors because they have insomnia. And in people with very severe depression, they can sometimes end up on antipsychotic medications. And all of these treatments can cause impaired balance, sedation, cognitive impairment, low blood pressure. So lightheadedness when they stand up, and then a propensity to lose their balance. So the treatments are certainly a risk. But what we know is that in the studies that have looked at this, that treatments and depression are actually independent risk factors. So you can have someone who's not depressed and on an antidepressant, and people who are depressed and not on an antidepressant. And when you look at all these groups, they all separately have increased risk of falling. So it's not simply that people who are depressed are at risk of falling through their medication. In terms of common risk factors, we think about cerebrovascular disease. There's this phenomenon of vascular depression. So people who have had either strokes or simply occlusions in their brain, so areas of their brain where that are not getting enough oxygen, that are not full strokes. And when you get a certain amount of this damage in the brain that accumulates over time, people develop a vascular disease in the brain, and vascular depression and gait disorders are very commonly linked by that sort of pathological process. People who are in poor health with a lot of chronic medical conditions are more at risk of falling, more at risk of developing depression. The same is for people with a lot of physical disabilities and people with cognitive impairments like depression. They're more at risk of both of these two things independently. So a sort of link in terms of common risk factors. People who are on a lot of medications are at risk of falling. And it seems that people who are depressed end up on a lot of medications. That particularly we know having 5 or more medications place you at a much higher risk of falling. So that's another common risk factor. So overall, we're looking at, it's not a simple relationship between depression and falls in older adults. People who are depressed fall more often, and there are multiple of different routes why that might happen. In addition to falling more often, and separately from falling more often, people who are depressed are more likely to break a bone. And this is true of older adults, but also younger adults as well. So if you, in this study, they followed people over a number of years and looked at the proportion of people who had not broken a bone over that time. And so you can see here that in the darker line are those with depression. And so a larger proportion of the people with depression over this time period have had a bone fracture. And so again, that's independent of their risk of falling. And what we have found in studies is that depression is actually related to osteoporosis in older adults. If you're depressed, you're more likely to have thinner, weaker bones. And it could be a number of different reasons. We think about depression as being an inflammatory disease, and when people are under stress, they get high levels of stress hormones, and those are have a very negative impact in terms of bone health. People who are depressed are less physically active, and physical activity is really important for maintaining bone health. And people, they may even get outside less. They might get less vitamin D. They may have less calcium in their diet because of malnutrition. So all of these things can be related to osteoporosis. Antidepressants are also suspected now, especially in people who use them long term, so over many, many years, to also promote bone loss in older adults. So there's, again, a number of reasons why people who are depressed are more at risk of breaking bones. So I think about this as a sort of depression deconditioning cycle. And there is some evidence for this kind of model when you think about what happens to older adults who are depressed. And sometimes it's hard to know where people enter this cycle, but if we start with the premise that they've developed a depression, they may have symptoms of loss of drive, loss of motivation, loss of activity. They are anxious and fatigued. And as a result, they're not doing very much anymore. They're avoiding going out. They're becoming more isolated, less physically active, and they may develop a fear of falling. As a result, there's a deconditioning that happens. They lose muscle strength. They develop impairments in gait, and they may develop thinning of their bones, and then that places them at risk of falls, fractures, and physical disability. And then that feeds back into the loop, because the more disabled they become, the more depressed they become. So how do we intervene in this sort of cycle in older adults? So to prevent falls in older adults who are depressed, there are very few clinical studies really that have taken this focus. We don't have a lot to tell us that this particular intervention will actually prevent falls. We know what improves depression, and we also know in a sort of general population of older adults what can help prevent falls, but those things haven't quite been put together yet. What we think it makes sense is to treat the depression, and to start off with, if possible, in people especially who have mild or moderate depressive symptoms, that they should try non-pharmacological treatments first. So avoiding getting into that loop of starting antidepressants and potentially increasing the risk of falling through medication. And so there are a number of psychotherapies which have been shown to be very effective in older adults for treating depression. And so these are things like cognitive behavioral therapy, relaxation therapy, mindfulness, problem-solving therapy. So those are all really good options. Psychosocial interventions would be things like social groups, other kinds of programs that bring people into contact, social isolation being a big risk factor for depression. And I think the thing we have the most evidence for is for exercise in this sort of loop. So we know in older adults that exercise is kind of like, it's like a triple whammy. It's effective on 3 different fronts in older adults. It's effective for treating depression, it's effective for treating falls, and it's effective for treating cognitive impairment, which is a risk factor that, you know, is sort of in the middle of all of this. The kinds of exercise I'm talking about are things like we have evidence for are resistance training, balance training, different kinds of aerobic exercise. Even something as simple as a social walking group has some evidence for helping with depression in older adults. Tai Chi has some evidence for both depression and for falls. And I've done some research myself into falls prevention programs, and the way in which this kind of pulls together both the exercise component and the psychosocial component by bringing people into groups and offering them the sort of psychosocial supports, as well as a focus on increasing their level of activity. So in summary, we know that depression is a risk factor for falls, that there is this sort of complex relationship that's bidirectional and involves multiple different pathways, but that clearly depression is independently a risk factor for falls, separate from the treatments for depression. And that the best evidence we have is for using exercise programs. The challenge, how can we deliver these exercise programs to older adults who are depressed and isolated? And that's something that I'd like to keep working on. Thank you.
Thank you so much, Dr. Iaboni. I was wondering if anyone in the audience has a question for her.
Talking to the mic here. So one of the themes we've been talking about is, you know, preventing falls is obviously a huge focus, but it's just as important to keep people active as long as possible so that we don't enter into this deconditioning cycle. And it just struck me how much I didn't realize that if you are faced with depression, that you also are at risk of this getting into that same cycle of inactivity and becoming more likely to get into falls. So I found that particularly interesting. Yeah.
I think that depression is a bit overlooked, but it's really central, because if it's such a fundamental thing, being motivated to move, motivated to be around people and to participate, and that's what's lost in depression. And we know that as people stop being active, they're more likely to develop depression. That it is a kind of like mood stabilizing effect of exercise. And I mean, people who exercise a lot will say that, if I don't get my exercise in, I'm in a terrible mood, I get more anxious, I need to go to the gym. And so it has that same effect in older adults as well. And so, yeah, I think depression really needs to be included in that whole cycle. Yeah.
I was wondering if you could talk a bit more about how cautious gait and a fear of falling actually increases your risk for falling, like kind of the more mechanisms behind it.
I mean, I know that that's work that has been done by Brian Mackey here. And so my understanding of that is that it's a kind of preoccupied walk, right? That a lot of our walking is not so self-conscious, that we walk fairly automatically. But as soon as you become preoccupied with your walking, it becomes unstable or irregular, and people take these sort of maladaptive postures. So I had someone recently who was walking like this. He was so anxious he was falling, but this is actually not the best posture really to take. He's not as stable as if he had been standing upright. So an anxious gait is often, and sort of an anxious, preoccupied gait is less stable than a natural gait for those reasons.
So thank you again. That was a very interesting talk. I think a lot of people don't realize that there is that link between depression and falling. So it's really interesting to learn more about that. Please join us again on Monday. We have another talk with Dr. Avril Mansfield, who will be talking about exercise. What are some different effective exercise that can help reduce fall risk? And we also have a tour scheduled on Monday after the talk. So please join us for that. Thank you.